Good morning, everybody, and you're very welcome back here to the National Clinical Programme for Critical Care second conference being live streamed here today from Dublin Castle. We would have loved to have you all here in person, but obviously with the current guidelines we can't, but we would sincerely hope next year that we will see you all here in person. In the meantime, I'd like to introduce you to Dr. Brian Marsh. Brian is a consultant intensivist in the Mater Hospital and is also the critical care lead for the Ireland East Hospital Group.
Yeah, thanks very much, Una. Good morning, and my thanks to the Critical Care Programme for inviting me to speak, and hopefully you'll find this interesting. It reflects upon a particular part of the service for the last 2 years, the Ecmo programme, which is defined as Mater Ecmo service on my slide here, but it really would be fair to describe it as more of a national service, reflecting the input of so many people across the nation. So that's our talk, and just for those who aren't that familiar with ECMO, what we're going to talk about today is veno-venous ECMO, which is respiratory support. It's a form of extracorporeal life support, oxygenation, for those patients who have come to the point where, although they have potentially reversible severe lung injury, they've exhausted the potential for maximal conventional supportive therapy. So it's those patients who really have a very high risk of death at that point in time, and that's when they're being referred on to this particular service. Important equally to reflect that it is a service. It's not really about the machinery per se. There is an important element of equipping, of course, but the service element, the training, the education, the expertise is really what builds the service and makes it safe. And prior to 2009, this service was primarily a treatment abroad scheme service for Ireland adults. We used to send patients to Karolinska in particular in Sweden. And I think, in fact, still some patients are being transferred to Karolinska for pediatric ECMO, and hopefully that can be repatriated as well in terms of the financial gains to our system and indeed the more empathic approach to patient care by having them within our own country. But if you look at this particular image that I have up here, you can see that, like everybody else, we started small in 2009. This is the time of the H1N1 flu pandemic, you might recall. A lot of fear at that point in time that we'd have a pandemic similar to what we've just undergone over the last 2 years. But in fact, the impact was less. But very timely start of the ECMO program. And then it built over time to around about 18 patients median per annum, as you can see. Fairly steady on the blue. Blue there is the veno-venous ECMO, so respiratory ECMO we'll call it. Red is cardiac ECMO. And we seem to go through a plateau phase where the amount of severe adult respiratory distress syndrome was a little bit more manageable, perhaps reflecting differences in critical care, both pre-ARDS phase and during ARDS phase. Really not terribly sure, it's speculation really. And then we came to the 2021 influx, which, as you can see on the right-hand side there, is quite significant. But the amount of veno-venous ECMO the respiratory ECMO really pushing right up, and cardiac ECMO remaining somewhat more stagnant. The impact, as you can imagine, on our service was very significant. Just to talk you through this a little bit, if you follow the blue graphic, that's respiratory ECMO days, so the amount of days that we devoted to delivering ECMO service to the patients. The light green is the total of all ECMO, respiratory plus cardiac. ECP or resuscitative ECMO, which is really a very small volume in our practice. But if you follow the blue, you can see that we tripled the amount of ECMO days from about 200 to nearly 600 ECMO days in 2021 alone, which is quite a stretch on the system as it currently exists. Now, the reason for this is the duration of ECMO as much as anything else. So the duration of ECMO, respiratory ECMO for COVID-19 patients, was close enough and double that of standard other indications for respiratory ECMO. So we're about 20 days median of respiratory ECMO for these COVID-19 patients. So it's a lot of investment of time into the patient care, hopefully towards a good outcome, of course. And as you can see, this is a little bit more difficult to read, I think, but if you follow the total map there, this is January 20 to January 2022, and you can see in the middle there the COVID-19 cohort of patients. Ongoing care, of course, for cardiac ECMO, ongoing care for other indications for respiratory ECMO, but COVID-19 there in the middle, you can see, we don't have a pointer, but on the left-hand side as you look at it, you can see there's 3 postpartum patients there. which all went through successfully towards decannulation and survival. And then towards the right-hand side of that, COVID-19 indications, respiratory failure, other adult patients, again with an overall survival of just around about 50%, which is consistent with international norms at the moment. Our retrieval numbers went up a lot. We tended to retrieve nationally around about 7 to 10 patients per annum. Big investment in time. This is difficult because it's very complex as a transport. You can see there on the top right-hand side the complexity of one patient being organised as an Ecmo transfer. But indeed, we have to reflect that transfer of all critical patients is complex. We can see on the right-hand side as well, the cohort of those 17 patients are quite nationally distributed in terms of how they're referred to the matter, and no particular region more dominant than the rest. We've had about 320 COVID-19 referrals into critical care in the matter that we've taken on since 2020. And 69 of those I've listed on the right-hand side as you look at it. Again, very nationally distributed. Of the 34 on the right-hand side who were retrieved or put on ECMO after retrieval to the matter, we can see again that the national distribution is quite broad. In fact, only 4 of those start off in the matter itself. And I guess that probably reflects quite an even distribution across the larger centres. In the middle, you can see, in fact, the complexity of one of those transfers. You can see that it's occupying 2 ICU physicians, an ICU ECMO coordinator, perhaps an ICU fellow at the same time, the patient, all there in the back of that ambulance working away. So it's a difficult, challenging trip, but thank God, to date, that's gone very well. It's a good time to reflect upon the work of the MICAS service, in fact. I've Dermot Doherty and Anne-Marie here, in fact, at this meeting, and I'm sure they're going to talk through some of this data later on themselves. They're not going to steal the data, but just to focus on the issue that there's a huge increase in MICAS transfers around about the January-February mark 2021. We can see on the right-hand side all those hospitals taking in those patients, but this is really very high volume, highly complex work. And so as part of this talk, I'd like to thank them for the support for our system, in fact, because they allowed us the utilization of their ambulance system, turned it on really by return of call every time that we looked to head off down the country to pick up a patient. So my thanks to them. But also my thanks to the MICAS retrieval teams themselves. It's not always matter service, the ECMO is, but there's so many of these patients, as we see, came in delivered by other retrieval teams of, be that Galway, be that Cork, be it Vincent's, Beaumont, James's, etc., all delivering and working hard to deliver a very safe service. So I'm sure Dermot will talk through that later on, and that should be quite interesting to listen to. What about the conversion rate of patients to ECMO? And this probably interests people quite a lot in the referring side of this particular equation. Because, of course, you have a patient who you're very concerned about, who's got refractory hypoxemia, very difficult to ventilate, very difficult to look after, and should they or should they not be referred for ECMO? Now, at the start of the program, at the start of the COVID-19 impact pandemic, we set up this app-based service. So we kept a good record of all the referrals that were made to us. And as you can see on this particular slide at the top, we've captured 165 of those referrals. The headline figure is probably that at the very bottom. If you look there at the UK conversion rate of ECMO referrals to a decision to go on ECMO, it was around about 13% for wave number 1, about 9% for wave number 2. And this data has been checked against the Papworth figures. And in fact, it was presented at a very good conference here back in third quarter of 2021, the Irish Congress of the ECMO Congress, which is primarily staff from CHI and from ourselves. So this is kind of a useful reference point to me. Are we taking the right number of patients? So around about 13% conversion rate for the UK. So if we look at these 165, which we've drilled down into, we can see that of those, 50 of those patients were transferred to the matter. So 30% of referrals were transferred. Of that group, of that 50, 25 of those were transferred on ECMO, so that was a retrieval. Now, this is dynamic numbers. You'll find that the numbers change a little bit per slide as times change, because, of course, between last week when I wrote the first slide and this week, numbers have gone up again. But about 25, about 50% were transferred on ECMO, so they're retrievals. That compares to 17 that I talked about a few slides ago. We would then transfer a number of others who have refractory hypoxemia, but we're not quite sure ourselves, should they be going on ECMO now or not, and they're transferred in, and a percentage of those then also go on ECMO as well. So as we can see, the row below that, I'm looking now at transferred on conventional supports but later commenced on ECMO. That's a further 12 patients, so 24% thereafter. So the total conversion rate is the bottom line figure there. The overall ECMO referral conversion rate is 37 of that 165, so 22.4% overall, compared to the 13% last known figure UK to me. So I don't know if that's represents the exactly best volume of patients to be transferred. It's a very difficult thing to work out. It's a very complex referral. It's very individualized. But I think at about the 22.4% conversion rate, it would appear to be a suitable position to be in. If we look at that impact then upon the delivery of the service itself, so particularly Jan-Feb, as we keep talking about wave number 3, very heavy influx of patients into all the ICUs. As we tried to keep the ECMO service going in the Mater, we had between 2 and 4 patients on ECMO on a given day, vena-venous ECMO, all for COVID for that whole period of time. Therefore, the amount of overtime shifts that the nursing staff had to do is kind of a bad phrase, but volunteered to do, engaged to do, simply did it, went up hugely. So we had 328 overtime shifts for nursing staff in that 6-week period, which is fantastic. That isn't only for the ECMO patients, because of course, as you focus on ECMO patients, you've got all your non-ECMO patients as well, which in fact are the majority. They require the same diligence and attention to care. So our non-ECMO nursing staff and our ECMO nursing staff all working together to deliver those 328 extra shifts. On top of that, we were fortunate in that we were able to draw on the capacity of others within the system. So our ECMO coordinators stepped from coordinating into actual bedside delivery of that care. Our CNM2s were involved, our clinical facilitators. Our perfusionists stepped out of the operating theatre, did a number, in fact quite a number, of extra working shifts at the bedside for the care of the ECMO patient, because of course they're very familiar with the technology, and many of them had started off as critical care nursing staff as well. So we're hugely advantaged by the availability of these people. Our advanced nurse practitioners have skills in this area. Some of our surge nursing staff were able to join in as well. So we had a lot of goodwill and support from other people coming in to do this work and to keep the whole process running along reasonably smoothly. Some of this you might have seen before. This is the run-through of the various waves of COVID. On the right-hand side, as you look at it, is the, as you can see, 1st to 4th wave and the different anchor points along that way. Now we can see how the ECMO demand increased as the 2 years went by. So wave number 1, in fact, we didn't have a huge ECMO demand. We were prepared for it, but it wasn't required. But wave 3 and wave 4, very significant indeed. So the numbers went up. I guess we also started to, I suppose as the numbers went up, the referral numbers, of course, went up, and that conversion rate then converts into significant patient numbers. But the overall survivor rate was 50%. And again, just to put a perspective on that, these are patients who, it is the sense of the referring clinician that they have exhausted the capacity to get these patients to a survival point. And then we get a 50% survival at the end of that. Again, consistent with international figures. So, again, I think reassuring, I hope. How do we compare ourselves internationally? So, this is kind of important in terms of how you accredit your centre, how you have a reference body for quality and safety, and for us, it's the Extracorporeal Life Support Organisation. We've, in fact, received a couple of awards from this group, which is, again, always nice to get. But more importantly, they ran this Euro-ELSO survey on COVID-19 from the start of the pandemic, and a lot of data gone in here. So, of all the sites across Europe, there's 202 participating sites. Some very high volume, some not so high volume. We sit in here with, on this particular data set of 10th of January 2022, We have 36 patients, I think it is referenced at that point. If you look around the sheet, you'll find some really very high volume countries like the UK and Spain and Germany. But you'll find that the centres, we kind of sit somewhere in the middle of centres in terms of volume. So there's some really quite low volume centres, some very high volume centres. So it's a variably distributed phenomenon across the European grid. This is the data from the very start, from the end of wave number 1 on the right-hand side as you look at it. And you can see that there's of the order of 1,500 patients admitted and converted into ECMO requirement in that first wave period. We can see at the bottom there, it's very hard for me to see actually, but it's 44% survival from that particular first wave. On the right-hand side, as you look at it, you can see that those numbers are now right up towards the 5,800 mark of patients in those 202 centres who've gone on ECMO since the start of COVID-19 pandemic. Huge volumes of patients. In the middle ranking, you can see that the patients who are still on ECMO, so that's 593, are not discharged from ICU as yet, so the final outcome data isn't something that we can really put a figure on at this point in time, except to say that it's looking like around about a 50% survival is around about where COVID-19 ECMO for this pandemic is fitting in. How much ECMO should you have for your population in COVID-19? There's been a traditional figure prior to COVID-19 that you need around four ECMO beds per million population, around about 20 ECMO beds for Ireland to be around about, 20 patients per annum is around about what you're going to get in respiratory ECMO for our population. Obviously for this particular disease, the demand has gone up quite a bit. But when you look internationally and say to yourself, well, should we have 5, 10, 15, 20 ICU beds devoted to ECMO, it's really hard to know. So I looked at this in terms of population base. And on the middle, beside the country column there, you can see the population in millions recently sourced. So we can see Ireland at 5 million, UK at 68 million people. And we can see that there's around about 7.2 cases per million population in Ireland, 8.7 per million in the UK, 7.9 per million in Denmark, which is often used as a reference country for Ireland. And at the bottom there, a median of 11.7 per million as the median across that whole network, but with huge variability, as you can see in there. So for instance, we have Switzerland, very highly resourced country at 34. Hard to know exactly what that requirement is. I looked at it instead in terms of ICU admissions on the right-hand side as you look at it. And again, the number of total ICU admissions, there is not a database at the moment that produces the total number of ICU admissions across each of those countries. What we do know is that for Ireland, we have around about 2,300 ICU admissions. Listening to Michael earlier on, it's now more at 2,600. UK, a huge influx of patients, as you know, 50,000 plus patients. And it gives us a ratio of around about 1 patient out of every 65 ICU admissions for Ireland, 1 for every 85 for the UK in terms of ECMO conversion. So it's information. It's not terribly clear what to do with that information because those different jurisdictions had completely different surge events. The UK had a very, very significant influx of patients in wave number 1, as did Italy, as did Spain. We've been somewhat lucky, I feel. We have not been overwhelmed. We've been pushed to the edge, but not overwhelmed. So we're not really comparing like with like, but we're informed, I think, by knowing that we are somewhere in the ballpark of European average. So how do they deal with this internationally? If you look at the UK, this is the national referral pathway in the NHS England, NHS Scotland. If you look at that map, what you have for Ireland is a 5 million population and 1 centre. For the UK, that's 6 centres. There's 7 on the map there, but 1's repeated. So there's 6 centres UK for 68 million people. So again, it's information. They had a very nice referral network, a centralised referral pathway, and a very nice, and they still do, I'm sure, communication, where there's agreement achieved between clinicians as to which patients should go on ECMO and which patients may not necessarily benefit. So good network coordination, big society, the UK, 68 million people. We're small at 5, of course. But it is interesting, 6 centres for 68, 1 centre for 5. I always find looking at Paris kind of interesting. They have an incredible ability to rise to significant healthcare challenges. We looked a few years ago at the extraordinary response that the Parisian healthcare community did at the Bataclan terrorist event, mass casualty event of 2015. Looked after an enormous number of casualties in a very quick manner through their now famous Plan Blanc system. Now, if we look at this particular, the Ecmo Surge for them, and this is wave number 1 that we're looking at here. If you look at the red line, that is the available amount of Ecmo circuitry to the Paris region, as you can see, rapidly depletes as the patient numbers in the blue line go right back up. And then a rapid delivery of new systems to keep that whole network afloat. And on the right-hand side, you can see the number of Ecmo cannulations on a given day during that period of time. So they were very, very busy. And again, in Parisian style, rose to that challenge in their incredibly efficient way. We can look at it here, and they divide up their centres into 3 types of centres. If you see that across the bottom, really, you can see 51 centres without the capability for Ecmo, either cannulation or for management. In the middle, you've got a group of centres who have the capability for Ecmo management, but not for cannulation. And on the right-hand side, you've got centres who have the ability for both Ecmo cannulation and management. And this really underlines to me the expertise required to run a very safe service. And this is quite an investment in time and energy. In the middle there, you can see their Ecmo mobile team, where they did 212 cannulations outside of that central ICU, and then transferred 154 patients, plus 11, into those centres which either have Ecmo cannulation experience and management, or simply the ability to manage those patients once the Ecmo cannulation is achieved for them. So a lot of movement, and therefore when you look at the data, you'll find that Paris has the biggest number of patients in terms of vena-venous ECMO for COVID-19. So very interesting. You can see the criteria on the very top there on the right-hand side. But in fact, I'm going to get back to that in a little bit of time, because it's another area that people have an interest in. What exactly are the contraindications, shall we say, to a patient going on to ECMO, and what are the pro-indications? If we look at their complications, again, this interests us, of course, because it's important to us that our complication rate is similar or less than the major centres. So this is the Paris data again. And you can see that the requirement for renal replacement therapy at 43% is obviously quite high. And I'll show you the Matter data in a few minutes' time. Another very significant complications as you work your way down through it, thrombosis of an Ecmo circuit is that which puts the Ecmo circuit at risk of going down rather instantaneously, so that's always a big concern. Massive hemorrhage, of course, they're at 43%. That's a patient who requires more than 3 units of blood in a given day. So it's a high-risk process and comes at significant complications, which, of course, you always want to keep to the absolute minimum. About a 12% cranial hemorrhage rate, which is, again, significant enough. If you look at the Matter data, we did have complications, of course. We did a lot of circuit changes. Nearly 50% of patients required a circuit change. And that's because the risk with the COVID-19 patients of circuit dropout with thrombosis is that bit higher. So none of these were a problem. They were elective changes. We had much less hemorrhage problems in the Parisian group. We had fewer problems in terms of neurosurgical interventions. We only had 1 intracranial bleed. We have a very high rate of renal replacement therapy, and that's largely because when we put somebody in ECMO, we tend to put a filter on at the same time in order to manage their fluid balance and their water. So not without its complications, and each of those complications is not insignificant, as you can see. Our outcomes, similar to EuroELSO, 44% versus 50%. And again, over the course of time, I won't take you through the slide, but again, it says the same thing, that the outcomes vena-venous ECMO have been consistent with the EuroELSO and the outcome data. So again, that's reassuring from our perspective. Just to focus a little bit on the referral criteria. Again, very busy slide, you don't need to read it all. Those of you who are involved will know the referral criteria. And ours, which you'll find on our website, are very similar. The thing that always raises some discussion is the duration of mechanical ventilation prior to going on ECMO. Is there a point in time where it is too many days of ventilation and therefore not a valid referral? And there's a discussion around this, in that the UK system is very focused on the 7 to 10 day mark. They do take patients beyond that, but they'd emphasize the value of earlier cannulation. We don't have that in our system. What we have in our system is a patient-to-patient discussion, clinician to clinician, but with a focus, yes, longer is of concern. But this is some data coming out from Austria recently on 101 ICU patients, COVID-19 ECMO. Blue is those patients who are mechanically ventilated less than 7 days prior to ECMO cannulation, and as red is those of greater or equal to 7 days. And as you can see, the survival probabilities are very similar. So it's unclear, is duration of ECMO necessarily a break point in terms of that decision. For our own data, we have on the right-hand column, I'm being advised to try and wrap up this talk a little bit, but on the right-hand side, you can see that the shorter cases, less than 7 days, had a higher survival rate of 62%, versus the 8 to 13 days at 40%, greater than 14 days at 60%. And if we just wrap up the greater than 7 days into a totality, comes in at 46.7% survival. So yes, it would appear that shorter duration of mechanical ventilation prior to ECMO might confer an advantage. There is a discussion as to whether non-invasive ventilation prior to ECMO might equally be part of that total ventilation count. So it's difficult. But the other thing that you can't really be terribly sure of is if you put some patient on ECMO earlier, would they have survived anyway over the long term without ECMO? And this is one of the difficulties that the randomized controlled trials prospectively done for this disease for ECMO have not been able to be done during a pandemic context. So it is difficult. And hence a patient-to-patient, or a clinician-to-clinician, individual patient conversation. Just in terms of how these patients done, we've managed to follow up the patients in our post-ICU clinic. Dr. Mairead Hayes leads this and has been generous by offering me some of her data. We can see that the majority of patients come in as a frailty score of 3, so independent patients beforehand. They now need a little bit of help, but broadly speaking are independent post discharge from hospital. And the majority of the other problems tend to be mobility-based. We have some data on their myopathies, which, like all long-stay ICU patients, it is not surprising that 100% of those patients have a myopathy of some degree. LTOT is long-term oxygen therapy, and we've been seeing these patients in the outpatient clinic following up their improval over time, and we don't know as yet, but my expectation is that at the end of a year, the data will be much more interesting. ECMO cannulation complications is things such as neuropathies from femoral cannulations. We have one patient who required a fasciotomy, so there's healing and recovery time there. And medical complications, we're thinking about things like atrial fibrillation, chronic cough, for instance. There's quite a chronic, nasty post-COVID cough, which for at least one of our patients was responsive to steroids. So that was, again, value to the patient. You'd worry a lot about mood disorders, anxiety, depression, post-traumatic stress disorder. Less than you would have imagined, in fact, but something that we measure with our post-ICU clinic psychologist in particular. Sleep disorders, cognitive impairment, minor, thank God. But overall, that group of disorders, anxiety, depression, post-traumatic stress disorder, I would have thought they'd be much higher, but they're less than I had predicted. And again, just to reference the group who run this post-ICU clinic, it's a very much a multidisciplinary clinic of physiotherapy, clinical psychologists, and our advanced nurse practitioners, and indeed ourselves, of course. So it's again, requires an investment of time. Finally, this is, as you can see, the most recent publication. This is January this year. And it's looking really at what are the indications for ECMO in COVID-19 patients, making the point that time is moving on, that we're learning all the time, that there's new therapies coming on board, that there is a need to refine exactly what the indications are, indeed what the duration of mechanical ventilation should be prior to ECMO, what's the impact of vaccination, what's the impact of different variants, who are the most select, or the best way to triage the group to offer the best opportunities to the largest number of people. So this is interesting. But it's, again, I'd have to say, it's still unclear, so we're still working with our established referral criteria. Finally, I really have to take a minute to go through this slide because these people have made the whole process work. We've Ed Carton, of course, who many of you would know, and Serena Bryan, who really had the vision to set up this whole program 10, 12 years ago now. We've ECMO coordinators, 3 of them. We've 45 plus ECMO trained nursing staff, and indeed all the accredited nursing staff to help run this program. We have the perfusion staff who came in to help out, and indeed have helped out all the time, but now have occupied some nursing shifts for us to help us get through this. We've all the other critical care nursing staff, and indeed the surge nursing staff, who have come in and done extra shifts to keep this whole thing going. My intensive care non-consultant staff, who've had to learn really rather fast at night in difficult and complex times. We've the MyCast paramedicals expertise and the retrieval out of hours, where they've come back late at night, taking us down at weekends without complaint and really at the touch of a button. We had your HSCP staff, huge investment of time, energy, in ICU, in isolation cubicles, post-ICU rehabilitation, and now in our post-ICU clinic. We work to the ELSO standards in terms of quality and accreditation, and I think that's really central to guiding us both now and into the future. Drs. Hastings, Mairead Hayes, and Serena Bryan for providing much of this data. And one thing which I didn't put on this slide is I should also recognise the work of the hospitals referring, because every time we go to retrieve a patient, it is incredible the organisation that we see when we get there and the help that they give us to get the patient organised safely and transported with us back to the Mater Hospital. So they have been, again, a huge part of making this a safe programme. It's a big team. I won't talk you through all that slide, just a happy picture. And thank you very much.
Thank you, Brian, and thank you to everybody in the Mater who provide this excellent service, the Ecmo service. Our next speaker is Eileen Whelan. Eileen is the Chief Director of Nursing and Midwifery with the Dublin Midlands Hospital Group and is the current chairperson also of the Hospital Group's Chief Director of Nursing and Midwives Forum. Eileen is also a member of our multidisciplinary acute operations critical care surge capacity meeting. So I'd like to introduce you to Eileen.
Thank you very much, Una, and thank you to the Critical Care Programme who've invited me to speak today. Hello to the critical care community out there, and hello in particular to colleagues online. I've been asked to talk about the Critical Care Workforce Plan, a document that was published in 2021, and I'm just going to touch on the context and the content of that document. But in the space of 20 minutes, I will be talking about 6 years of work that has been very, very professionally led and coordinated by Derek Cribben, the lead nurse on the critical care programme. But Derek has coordinated that work with many of the critical care nurses out there online today and with our chief directors of nursing and midwifery across each of the hospital groups. So there is no way that 20 minutes of me presenting here today will in any way give you a true reflection of the time and commitment that has been put in, but also the planning that is there to deliver on what I see as a very optimistic plan, but actually a very realistic and achievable plan. For everybody who's been involved in healthcare delivery to date, the vision and the strategy of our healthcare system here in Ireland is strongly focused on delivering a healthier Ireland, but also is about the right care in the right place at the right time. Central to delivering that care is improving access for our patients to care. And for the critically ill patient, that definitely means increasing the numbers of critical care beds in our country. Improving the quality of care is absolutely core, and that is monitored scrupulously and daily by the National Office for Clinical Audit and led by Rory Dwyer, but also hugely contributed to by a number of clinical audit nurses in each of our intensive care units. Central to the increasing capacity are a number of reports which many of my colleagues have already touched on, and they include the Prospectus Report from 2008, the Model of Care for both Pediatric and Adult Critical Care, a previous workforce planning report on nursing setting out the census data during 2018, and our most recent bed capacity review from 2018, highlighting the increase required of an additional 190 beds. We are now at the point when the expectation is that we will deliver and we will have real action. Our Minister has announced since 2021 that we will have an increase in the ICU bed capacity from 255 beds to 465, and that this will happen in 3 phases. As I stand here and present to you today, we have already moved between phase 1 and 2, and we are achieving 299 opened ICU beds as of yesterday. But the challenge that lies ahead in relation to the delivery of an additional, in excess, the number is moving in similar to what some of my colleagues have said, but to deliver to an additional 465 beds is phenomenal. And it requires serious and multi-annual planning in relation to the nursing workforce plan. But not only is it about numbers in relation to delivering on the nursing workforce plan, it is absolutely about the experience and the qualifications that those nurses working in ITU will have, but the opportunities that they will have to foundation courses and postgraduate education. In a way, I apologise because I'm going to set out the building blocks that have led to the workforce plan, and I'm conscious that I'm talking to a critical care community of doctors, nurses, health and social care professionals, and many others who already know the detail of this data. However, the target that we need to achieve is so phenomenal. It's important that people understand the building blocks that have got us to that point. So our Irish Association of Critical Care Nurses, currently chaired by Anna-Marie Murphy, and Anna-Marie has had huge contribution in supporting the critical care staff during the recent pandemic and during surge challenges. But also the standards in relation to staffing levels are endorsed by the British Association of Critical Care Nursing and the Joint Faculty of Intensive Care Medicine, the Irish Society of Critical Care Medicine, and also the Critical Care Programme. And each of these professional bodies and associations is endorsing the information that is set out by each of the others. So there is no disparity. So what is very clear is that for the level 3 critically ill patient, that patient requires one-to-one nursing care. And from what Dr. Marsh has previously set out, many patients, the Ecmo patients, plus our dialysis patients and others, require in excess of one-to-one care. But what is critical in addition to the one-to-one nursing care is the support team that critical care nurse at the bedside requires. And that support team includes clinical educators, clinical nurse managers, healthcare assistants and audit nurses. And these are not an addition, these are an essential requirement to delivering the critical care service that we are required by the standards and that we are measured by the NOCA ICU audits to deliver on. And when we talk about retention of critical care nurses, which is critically important as we plan and try to deliver on additional beds, we will not achieve this unless we stand together to ensure that we appoint our clinical educators, we appoint the additional access nurses, and we ensure that the supports of clinical nurse managers and others are in place. I've mentioned throughout my presentation that it is about a nursing team, not just one specific group of nurses, but the ICU nurse is working in partnership with the multidisciplinary team. However, I have set out the ratios, which as I speak today, we are not currently delivering on these ratios of one clinical facilitator to every 50 nurses working in ICU, one clinical nurse manager to every additional 8 beds that will go into play. Also, one audit nurse for every 10 beds, additional healthcare assistants to support the work of the critical care nurses, and also we achieve additional capacity by building up our ICU outreach teams and our advanced nurse practitioners who will work both within and outside of the ICUs, and particularly in the significant role that they play in relation to the MICAS transport system. So definitely don't need to go back. So in order to increase from where we're at today, we have collected data, and thank you again to Derek Cribben for the exceptional work in the data collection, in relation to the number of nurses that are approved today, the numbers of nurses that are in post, and the number that we require to meet the current standard. My data is based on 280 beds, but obviously we are now running at 299, but the gap is still the same. And you will see that we are significantly below, about 50% below the numbers of nurses that are, not 50%, about 20% below the numbers of nurses that we have in post and the number of nurses that are required to deliver care for our most critically ill patients in the acute hospitals. If we look at this data across all of the hospital groups, there's very little difference. So the gap exists in Model 3 and Model 4 hospitals, but also equally across every hospital group. And that signifies to me that there are a number of issues here: financial, process, but also availability in relation to ensuring that we have a readily available workforce. But financial and process are probably the two biggest challenges. The reason that I focused on the basic steps, and even though I'm talking to a very experienced audience here, is because the achievement is phenomenal. Today, when we look at the number of staff nurses in post in relation to critical care, it's 1,489 staff nurses, when we actually require an additional 1,545 nurses to achieve what is set out and to achieve the Minister's expectation of 465 beds. I'm stating that number, and we all understand that the national turnover is around 7%, but can be higher in critical care. And that's the number of additional nurses that are required, not recognising that the current staff nurses will be the staff nurses that are promoted into shift leader posts, into clinical educator posts, and into our future posts for advanced nurse practitioners working in both inside and outside of the ICU. So the challenge here is phenomenal, but it's not unachievable. And it will be achieved based on how we continue to recruit, because recruitment has been well managed at hospital level to date. And year to date, in excess of 200 ICU nurses have gone into post. Over a 5-year period, close to 700 ICU nurses have gone into post. So we need a very systemised approach in relation to both how we recruit and how we ensure we're educating our critical care nurses. But we also need to facilitate greater opportunity for nurses who are showing an aptitude and a desire to come and work in critical care. So this table is a very basic table, but indicating that for opening 10 beds in any 1 year, we need to recruit 60 nurses and also train and educate 60 nurses. But to achieve any of this, we need our nurses in post a minimum of 6 months before our ICU beds open, and we need our clinical educators in post 6 months before our nurses come into post to prepare the area, but also to work with the current critical care staff that are already in post. On any 1 year, my expectation is that we will even need to exceed the numbers that we have set out here, and that we will need to be recruiting circa 150 ICU nurses a year and allow for turnover and promotion on top of that. So this is evidence from a study that was carried out. It's a little bit maybe old now, in that the study was carried out in between 2009 and 2011. But it's a critically important study because it was carried out in Irish hospitals, but also in 14 countries across Europe. And the key message in this piece of research, Linda Aitken, among others, is the researcher, and she's attached to University of Pennsylvania, and very well-respected researcher. But it indicates that it is the nursing numbers and the skill mix combined with the education and qualifications of the nurses that impacts patient outcomes. And for anybody who has time to pick up that study and that research published in the BMJ in 2012, it really does indicate why we need the combined team of nurses working in our ICU, that it's not just single bedside ICU nurses that we need to add to our workforce. And also that our nursing numbers are impacting patient outcomes. Aitken's evidence is also being adopted now by human resource departments, because also your nursing numbers is impacting and your nursing teams are impacting the well-being and the outcomes in relation to staff. And we're in a very fortunate position at the minute where our chief nurse in the Department of Health is leading on safer staffing across a number of areas within the acute hospital. And Jonathan Drennan, our researcher from UCC in Cork, is also producing evidence that indicates the same as the Aitken research from the previous decade, that it's the nursing numbers, the nursing support structures, the qualifications of the nursing staff that lead to lower mortality, decrease in infections, decrease in pressure ulcers, and improved patient and staff satisfaction. So I've talked about the recruitment of the nursing numbers, and we see the huge challenge that's ahead of us. The other area that needs to be focused on with equal and as much intensity is the education and the professional development of our nurses. And what is really fantastic about today, this is a tipping point in relation to looking forward and being hugely optimistic about the future. But the work that we need for the 10 years ahead of us has all been achieved in the last couple of years. So again, the National Clinical Care Programme and Derek Crippen, working with the ONMSD and Dr. Geraldine Shaw, have ensured that critical care programmes are funded. In excess of 1,000 nurses will be able to access foundation programmes over the next couple of years. To date, I think it is 558 nurses have already undertaken funded programmes. But the education pathway was launched in 2017. And as well as UCD and UCC, there are a number of hospitals that are leading out on very highly accredited foundation programs and working with the universities and leading out on postgraduate programs also. And there's a very, very good tradition in this country of high caliber staff coming out of our postgraduate programs. So I just wanted to mention in relation to the critical care pathway that was launched in 2017, to date, just 30 of our graduates have commenced on that programme. Some of that is understandable because the last 2 years has been very different in relation to the environment and the opportunities for our graduates. But I would see from here forward that as nurse leaders and as people who have a significant interest in critical care, we need to be giving our graduates opportunities to work in the critical care area. And this is one of the excellent pathways that can really support graduates who choose to work in critical care. Tala Hospital have recently launched this pathway, but other hospitals like St James's and Cork University already have students on those pathways, and Tala Hospital are highly committed to starting their graduates on this programme also. Just in addition to talking about what we need to do internally within the walls of ICU, we automatically create additional capacity by building our ICU outreach teams and the development of additional A&P roles for both internal and external to the acute hospital. This is just a very brief snapshot of some of the data that is coming out of one of the ICU outreach teams in one of our large acute hospitals. And it's indicating just year on year the numbers of patients who were seen at ward level and who subsequently required transfer to a higher level or another level of care following review by the ICU outreach senior experienced nursing team. There is significant body of data from the hospitals. Galway University Hospital currently have an exceptionally good outreach team, as do Tala Hospital, St James's Hospital, and there's lots of audit data indicating better patient outcomes. And one of the significant indicators is a reduction in in-hospital cardiac arrests by 52% over the same period of time in one of the hospitals that is currently running the ICU outreach teams. So I take on board Dr. Martina Harkin's recommendation that we need to look at exit interviews in particular in relation to our retention strategies, and I think that is something we need to build into our retention strategies. But critically important, we are anticipating the report from the expert review body on midwifery and nursing in the next couple of weeks or months. In addition to that, we need to ensure that we have multi-annual workforce planning aligned to activity and that we are adjusting our workforce plans in line with changes and pressures within the system. If there was to be an ask from today, it is that we appoint the additional 23 clinical nurse facilitators that are required for hospitals around the country. And this will not only prepare the environment for the new nurses that are coming in, but give support to the staff that each of us in turn have thanked, but actually we now do need to put the supports in place for those staff. Additional factors just in relation to supporting retention strategies is supporting our nursing leadership and on-site education, ensuring that our critical care nurses are incorporated in plans by the chief academic officers in each of the hospital groups, that they have access to clinical skills simulation, that we as nurse leaders develop fellowships for the brightest and best in our ICU, that we support them to travel internationally to other intensive care units, but actually have a pathway where we're bringing them back also. And taking on board Martina's point, staff engagement and feedback, also the Employee Assist programme run by the HSE and the National HR Department has got very good feedback from staff who've required that support during the pandemic. And Rina Gillen, working in St James's, has been appointed to the board of voluntary organisation, Heroes Aid, that offers support to our critical care staff. So just moving swiftly along, because I'm keeping a close eye on the time. Delivery on this plan is, as I say, achievable, but key to the implementation will be the governance and implementation structure that is set at the acute hospital division. Core to the delivery will be the appointment of a director of nursing. At the minute, all of the recruitment is happening in individual hospitals and hospital groups, which is excellent, and it's a working system. But the size of what we need to achieve and the time frame that we need to achieve it in and the imperative to achieve it, we do need one senior nurse coordinating this and working closely with the chief directors of nursing and hospital groups. As my colleagues have highlighted, other elements in achieving this will be the infrastructure and the information technology. But it would be remiss of me not to identify some of what I see as the challenges, because once we all agree the challenges, then we can manage those carefully. So as a country, in relation to the number of nursing graduates we train each year, we are on the lower end, 28.9 nursing graduates per 100,000 population. I can say thank you very much to our chief nurse, Rachel Kenna, who in my diagram over here on student intake number, since she has come into post, is working and strengthening in the picture in relation to the number of graduates we're taking on year. However, in increasing the number of graduates, we need to ensure we have CPC supports and that we have the supports in the academic institutions to keep those graduates in place. Just in relation to nursing numbers, the nursing numbers across our acute hospitals have increased in the last 10 years by 5,674. Of that, there is about just over 700 ICU nurses that have gone into post. But when I look at that increase in numbers and the requirement of what we have to achieve as regards increase in ICU workforce and other workforces which will compete, we significantly need to look at the third diagram down here, first-time registrants. And what you can clearly see is that the number of Irish trained and first-time registrants is about 1/3 of all registrants that we have as first-time registrants in Ireland. So Ireland, combined with the EU, combined with the non-EU, is just about 1/3 of our total need. And in the next decade, our need is going to increase for both ICU, but also for other areas. So I see the achievement on the ICU workforce plan as absolutely possible with a lot of hard work and really good continuous planning. Achieving on the ICU workforce plan will allow us delivery on the national strategies, which are core to ensuring a healthier population. So delivering on the trauma strategy, the organ donation strategy, cancer, maternity and paediatrics. But competing with achieving on those strategies is also other and essential work, as is delivering on the safer staffing model for medical and surgical wards, delivering on the safer staffing model for emergency departments, and also on long-term residential care. 3 areas that haven't had an uplift in staffing, notwithstanding the change in patient epidemiology, acuity and dependency that we've had in our patient population in the last 2 decades. And this work is endorsed by the chief nurse in the Department of Health. So I see it important that we have an eye on what's happening in relation to the other areas. At the outset of my presentation, I intended in acknowledging all of the critical care team that has worked through the surge planning. And while I didn't do it at the outset, I would absolutely like to make a point of, on behalf of all of the chief directors of nursing and midwifery, thanking the critical care community that have delivered phenomenally through the surge planning. You have been immense in relation to your leadership, your clinical expertise and your commitment, and that is really appreciated by all of us who needed you. My closing remarks are that it takes a team to do what has been done over the last 2 years, but more so it will take that team over the next decade, and it will take that team from policy right down to frontline. So on behalf of the chief nurse in the Department of Health, Rachel Kenna, Dr. Geraldine Shaw in the ONMSD, who has funded and supported the nursing education over previous years, but also now going forward, and the 7 chief directors of nursing and midwifery. I'm not ignoring all the multidisciplinary team that we also work with, but I'm specifically thanking the nursing colleagues who I think deserve huge credit. And thank you in particular to Derek Cribben, who's here in the forum today, and also to Anna Marie Murphy, who's chair of the Irish Association for Critical Care Nursing. Darling for keeping it all together but leading it through the challenging times, and also to Eileen O'Brien, who supported the team of perioperative and peri-anaesthesia nurses working through the surge planning. So thank you very much.
Thank you, Eileen, for that wonderful presentation on behalf of the critical care nurses in our country, which help to keep the service going. Our next speaker this afternoon now is Carmel O'Hanlon. Carmel is clinical specialist dietitian in Beaumont Hospital with over 30 years clinical experience. Carmel is also a member of the critical care programme working and advisory groups. Carmel.
Good afternoon, everyone, and thank you for the opportunity to talk here today. Thank you to the organisers and the HSCP office for asking me to talk today as well. So first of all, I have to say I'm a dietitian, and I'm representing other health and social care professions and allied health professions as well. And I'm mainly going to talk about the therapy professions, or the people at the bed end or the bedside providing therapies. There's 26 different HSCPs, and I can't cover them all, but I do want to mention the important role of radiographers, clinical engineering, medical physics, clinical biochemistry, and others, but I'm just not going to cover them here. I'm just talking about the therapy professions here at the bedside in ICU. So I'm hoping to cover, well, the HSCP, AHP roles in ICU. Now, I have a stroke here for AHP, or allied health profession, because I'm including pharmacy here, because I think we can't talk about the HSCPs without talking about pharmacy as well. And just historically, they don't come under that, the HSCP umbrella. They come under as an allied health professional. I'm going to also talk about some of the pandemic challenges to all of us HSCPs and AHPs, and a little bit on workforce planning if I can as well. So a little bit on the roles. So what I'm covering is looking at is particularly as dietitians, medical social workers, occupational therapists, pharmacists, physiotherapists, psychologists, and speech and language therapists. And there are some roles that are common to all. This is just a whistle-stop tour of what we do, and some of you will be well familiar with what we do and some mightn't. So again, we have some commonalities in our roles, and we assess patients individually and depending on what profession we're coming from, and then we develop a treatment plan or individual care plan and communicate that to the nursing and medical teams and the anaesthetic teams, document it, monitor, discharge. We develop pathways and protocols, loads of those coming out during COVID as well, and training and education has been key during the pandemic as well, and research and audit goes on during the pandemic as well. So a little bit just talking specifically on just a couple of key roles, again, taking out just a couple of them because it's impossible to cover everything. From the dietetic perspective, there is a national clinical guideline that was produced in 2020 on the NCEC website on nutrition screening and the use of oral nutrition support. So screening is the first step, and nurses are in the unit. Sometimes it's the dietitian and the nurse who does the screening for malnutrition risk and also for the need for nutrition support. The dietitian will be involved in that, and then we actually assess patients. Nutritional assessment, we use the nutrition care process, which is an internationally recognised process, a structured process that looks at from nutritional assessment to nutritional diagnosis to outcome measurement and to follow up and to documentation. And we particularly look at, particularly because we're mentioning the pandemic and COVID here, refeeding risks. So identifying refeeding risks, the dietitian is clearly involved in that, as is the multidisciplinary team, and there is a lovely guideline by ERSPN, the Irish Society of Clinical Nutrition and Metabolism, on this that is used often as a basis to develop local protocols on this, on identification. And we also look at diagnosing malnutrition. So this is something that is firmly in the dietitian's role, and we, again, there's a whole set of criteria we use. And then providing nutrition support, and that's our bread and butter, or should I say our fruit and vegetables, is what we really need to promote. The nutrition support, oral nutrition support, enteral tube feeding and parenteral feeding. And we have a lovely document on the CCP website about an algorithm on starting up tube feeding and parenteral feeding. Now, from the medical social worker point of view, again, these are just a couple of things that are picked out. They're very much involved in assessing and addressing complex psychosocial circumstances of patients and families, clarifying potential misperceptions and enhanced communications, particularly between ICU teams and and patient families, and that really helps relieve some of the burden on nurses during the pandemic when you know, normally patients would go in, relatives would go in and be 2 hours at the bedside every day, and they get to know their nurses and what's going on. It's very difficult to communicate that over the phone, and medical social workers have been key players in trying to improve those communications as well, and improving quality of life for sick and dying patients and families. And I suppose there's been a couple of new, one in particular I think that I hadn't thought of really, was in the context of global travel bans during the pandemic. The medical social worker role has grown to encompass supporting families needing to travel from abroad to ICU in emergency situations. So they've been involved in organising, advocating, negotiating with immigration, airport services, governments and NGOs, and their role has really expanded. And again, they have always, as per usual, support communications between families and staff. Occupational therapists have a huge role as well. Their goal is really to minimise the effects of immobility, sensory deprivation and prolonged intubation. And they do that by a lot of treatments, which includes specialised seating, which helps optimise physical function, positioning and splinting, to address spasticity or prevent joint contractures, assessment of motor and perceptual and cognitive difficulties, and assessment of consciousness of the patient as well, so establishing the person's level of responsiveness, awareness of self and environment. Pharmacist, again, very, very important role in the ICU at the bed end as well, to ensure patient receives the safe and effective drug treatment in critical care, to help reduce adverse patient outcomes by reducing medication incidence and promoting medication safety. And they reduce drug expenditure, so they save the hospital money as well by promoting good prescribing practice in critical care. Physiotherapists are key. Oh gosh, they've a load of functions, but under two big areas: respiratory assessment and management, and the safe initiation and progression of functional rehabilitation. So they're very important and key, provide specialist assistance for microbial sampling of respiratory secretions, spirometry and respiratory muscle capacity, in-depth neurological assessments, musculoskeletal assessments and treatments, and positioning protocols. So that's all very important. And I just wanted to say here that they do provide a 7-day per week service and an on-call service for 24 hours a day. So they're really key there, and they have direct patient contact, and that's right. They're really brave people during COVID, next to nurses, and they're really, and clinicians, again, they're at the bedside, they're providing their respiratory management and the rehab management, and they're obviously close contacts with patients all the time. The rest of us are at the bedside as well, but not to the same extent, and not this within kind of a metre for that length of time. And just from Beaumont Hospital data, for the first wave in COVID-19, in the first 6 weeks, 28 patients were seen by the physiotherapist. There were 359 physio sessions, of which 84 were rehab sessions. And this required an average of 2.6 staff per rehab session for the physios. So that's really important. The psychologist is key as well to assess the psychological functioning of patients and their coping and adjustment on the unit. And they support the patient from the acute phase through to the outpatient stage as well, and they support psychologically for trauma-sensitive care on the unit. They screen and support common forms of, for common forms of distress, which includes PTSD or post-traumatic stress disorder, anxiety, grief, low mood, panic, and again, they support staff. So they're key to the unit, and they have been during the pandemic as well. But there's just a paucity of them, and I think they need to be represented more. Speech and language therapists, again, there's a paucity of those too, and they're very key in facilitating early effective communication. That's really, really important. Assessing and managing airway protection and tracheostomy weaning. And during the pandemic, they've been looking at different ways where they can reduce risk to their staff and also reduce risk to patients during this tracheostomy weaning and decannulation. They work with the physiotherapists closely and with the anaesthetic teams when they're doing this, and the nursing staff, of course. And they work closely with ourselves, the dietitians, when they're promoting safe return to oral intake. I just wanted to mention the other support staff that's not covered under the HSE umbrella, but that really are key for spiritual management, IT support, porters, secretaries, cleaners, the HCAs, food service staff, the catering staff, and ward clerks who are in the unit every day. So they're in the units, coming in every day, and also the staff that support that don't come into the unit, like supply staff and others. I just wanted to mention them. And here we are. I'm not going to go through everybody here. I was going to, but I just don't think there'll be time. But we have some ward clerks here. We have medical social worker here. We have HCA. We have physio. We have dietetics. We have medical social worker with speech and language, and we have pharmacy here. And this is really important. And we have nursing staff, a few nurses there as well. I hope they can see themselves if they're looking for a moment. I see you there. Some of the pandemic challenges, again, from a HSEP perspective, organising services, putting the patient firmly at the centre of everything we do and everything we organise. So we're looking at staffing like everywhere else and trying to use our experienced staff to train our less experienced staff, redeployment of staff from wards, from areas that aren't familiar with ICU into ICU, how to manage that, how to make sure patients are safe, how to mentor, again, staff training, the use of PPE, making sure everybody in the departments know how to don and doff and use it properly and preserve the use as well as much as possible, you know, to preserve PPE where possible, but to be sensible about the use of PPE. And again, equipment, there have been equipment shortages. So from physiotherapy, there might be some of the rehab equipment like combolizers and stuff, there might be shortages there, and trilogies and airvos and such like. In nutrition, that there could be feeding pump shortages, and so the companies have risen to the challenge, and we're able to provide us with extra pumps and to make sure that we didn't run out of feeds. There were some issues with parenteral nutrition supplies and parenteral nutrition vitamin supplies as well, and then that runs into medication. You know, our pharmacists have been working really hard to try and source medications, and they're running short, and they're competing with the European colleagues to get us the medications that we need, or the most suitable alternative, and developing loads of local guidelines, and again there'll be loads of other things. I want to mention that this goes on in the new units as well as existing units. So really there have been new units popping up, temporary units that are COVID units, and we've had to send staff down when, you know, there isn't even a place for you to put anything, you know, and there's no supply area, and you have to try and start from scratch, if you like. Service adaptations, again, with the patient firmly at the centre, how we do things. So communication on the multidisciplinary team, it's still really important that we communicate together. This is really important. And although we're individually giving our spiels about the different professions and the nursing, and we all muck in together, okay? We're all there together, and we've been doing that virtually if we can, but most of the time it can be face-to-face as well, remotely, using telehealth where possible. But then we have to be careful that we're not phoning the unit too much. So sometimes it's a combination of face-to-face and remote communication as well. Site-specific decisions on reducing aerosol generating procedures, clustering care, so that the person at the bedside can do as much at once to try and plan that, and again planning services to reduce footfall in the units where possible. When we're reviewing patients, we're making full use of the CIS if it's available, so that's the computerized information systems. So we do as much remotely as we can. If necessary, we ring down and we try and discuss with our nursing staff what times suit, you know, what times they're particularly busy at, which is all the time really, but to agree a time. And we call families more, whereas normally we would have met up with them in the units. But because of visiting restrictions, we'd have to call families to get histories and drug histories, you know, medication histories, or who's the local pharmacist, and again, nutrition histories from a dietetic perspective. And of course, there's face-to-face. But you try and have as much background information done, as much prep done, so that when you go in, you're ready to go, you have all the information that you need, and then you can be a little bit quicker reviewing the patient at the bedside sometimes. And again, I would check if I was going into the COVID ICU, I would check generally a quick check to see if there was an aerosol generating procedure like an intubation or an extubation going on. And then if that was the case, we would delay it for half an hour and go in maybe a little bit later. So again, communication is key here. There's a discharge process as well, and that's key for patients who are leaving the unit to the ward, that we make sure that everything is documented, that any hard copies of anything will make its way to the ward, and that they're followed up properly on the ward. So risk assessment for everything we do, we look at the patient and obviously ourselves and think of what's the risk-benefit ratio, what's the risk of what we're doing, is it needed? And acute phase, so as well as service challenges, there's clinical challenges, and I don't think I'll have time really to go through this, but the patient with COVID throws out a whole load of clinical challenges to all the professions. Prone position therapy, I've seen pictures of that where people are on the front, you know, trying to provide therapy to people who are lying for long periods of time on the front, and all the consequences and the debilitation and the pressure area problems that they have involves everybody from occupational therapy to physiotherapy to dietetics, how we feed those patients and the complications they can have. The AGPs is again urged the salt generating procedures there. And again, these patients have multi-organ failure sometimes, or they can go in and out of that. They're volume sensitive. The treatment effects like steroids are going to push up their sugars and their triglycerides, and we have to be cognizant of that. So we have to, everything has a knock-on effect to the service and the treatment that we provide. Rehabilitation needs to start early, and physiotherapists are on top of that. They will start rehabilitation as soon as it is appropriate. And our speech and language therapists will be looking out for dysphagia, especially when people are coming off the ventilators. They may be on, again, 30% of our COVID patients at the moment had tracheostomies inserted. They'd need to see all of those, as well as people on longer-term intubation who may have a laryngeal damage there, and pharyngeal damage too, or edema, just temporary, but they need to be monitored. Clinical challenges, the duration of ICU stay. So in our own unit, we know our COVID patients stay 15.7 days, say, was looking at 154 patients, a cohort of those, and the change in clinical status. So from one end of the day to the next, the other end, different things would have happened. So from a dietetic perspective, I know we've changed plans on multiple times, and we ended up reviewing some patients multiple times on the same day. The impact, the physiological impact, again, the physical impact of prolonged ICU stay on the patient, because they're mobile, because they have inflammatory reactions, they're breaking down muscle, and they become severely deconditioned. And that involves all of the health professions as well, and the service that we give. And we're trying to reduce the risk of protein breakdown from our dietetic services, and the rehab, the physio is looking to build up the muscle, you know, to try and as much as possible hold on to what the patient has got and build up. And the occupational therapist is looking at seating to make sure it's appropriate. And all the other, again, when muscle breaks down, your swallow muscle is affected as well. That will affect speech and language therapy as well. So the mental and emotional impact, so from the patients and families, is fairly obvious. The visiting restrictions and the isolation, the anxiety, they've all been mentioned, and I'm sure we'll hear more from our patient this afternoon as well. Prolonged ICU stay, this is very hard on patients, especially as they're getting better, and, you know, with the limitations on family visits, it's just hard. I've seen nurses doing little dances for the patients, you know, to try and get them upbeat and feeling a little bit better, you know, for the younger patients, trying to get them enthused and motivated and put a smile on their face. And again, a prolonged recovery and the quality of life issues. But also from the clinician point of view, trying to do remote versus face-to-face working, longer hours, shift working, we all changed to a large degree, especially those of us who are based in kind of loads in one office. We tried to do shift work initially until we could source other locations that we could spread people around to, changing more patterns and practices. Fatigue and burnout, definitely a big thing. Anxiety and quality of life, we were subject to the same restrictions as the rest of the public, so your home life is curtailed as well, and you can't really balance the kind of the dip in the work life, if you like. Psychological impacts, that this was provided by the psychologist, and I apologise, I won't be able to go through it in detail, but the themes in therapy, again, post-traumatic stress disorder, just to watch out for that, and also delirium and nightmares that can happen with patients after. And the loss and the grief, you know, you lose your sense of self when people are coming out, even their body image and the emotional distress. You know, the patients, they have a lot to deal with psychologically, and the psychologist is key there. And also staff psychological support, and we've all had days like this where we just want to lean up against something and not do anything else, but, you know, the psychologist is very important there, and social work, again, would provide counselling. And there's different, I definitely know as a department in dietetics, we've used the care space in Beaumont. It's been helpful. I think debriefing, especially for people, you know, when people have died and you've had a load of time invested and you get to know them, and it's really important, you know, and teaching input as well, psychology are involved there. So key learnings, importance of the multidisciplinary team, interdisciplinary communication, very important to keep that going, that we have historical staffing deficits, and that was a real issue, and you could see the cracks appearing. And then we had new bed staffing deficits as well, where there was new beds brought online without extra HSCP staffing, putting extra pressure on us. And then training, really structured training is needed for ICU care as well, and the readiness for a major surge again, so that we would have some kind of, we do individually, but maybe something that we could do together, maybe look at how we could structure this properly. And again, to recognise burnout, stress awareness, counselling, okay, and importance of supporting families, okay, so that this is really important here. So the achievements, I think, from services during the pandemic was that the service continued despite the challenges, and there was patient care prioritised, and this was a new disease that nobody knew anything about, and we were learning all the time, and we were educating ourselves and others, and training others as well for working in ICU. Research and audit, really important, and I'll mention that in a second. And again, new methods of practice. Again, for all of us, including shift work and all that, but also the new roles that people took on, and role development, very important. And this is a little bit on the research project, so I just picked out 3 that were international kind of, or national multi-centre projects. So the first one there is on speech and language therapists are very much involved with. It's part of a bigger project, but that particular paper was produced in June, and it is particularly relevant to ICU, so that's how I mentioned that. And then the COVID-19 nutrition study, which looked at what happens in the ICU and then afterwards, so that's ongoing, and that's international, okay, and then the ICUs in Ireland, the dietitians are involved in that, and the lead will be over in St. Vincent's, Prof Nichols over there, and Kate Ainscott. Again, novel drug treatment, so the pharmacy trials that the pharmacists will be involved in, huge number of trials, and more coming on board, so that this is really important as well. And that's just a sample of some of from my Matter colleagues and from my St. James's Hospital colleagues. Again, just some of the dietetic posters on looking at your service, what worked, what didn't work, the different modes of nutritional support, and just shows the complexity of the patients and the multiple modes of nutrition support needed. Workforce planning prospectus has been mentioned, that fed into the model of care, so it's really the model of care I've outlined here. It's really important, you know, that we try and get a ratio of staff that in our current model of care in 2014, there wasn't a ratio there for medical social work. We need that. Occupational therapy, again, clinical specialist level, they would prefer. It's equivalent to clinical lead in the UK, and pharmacists, again, very much indicated there. Physiotherapists, I'd just say that was, it's recommended based on patients needing 1 30-minute session a day, and now things have changed, so the international average would be recommended 1.5 sessions per day, so that needs to change. Psychologist is included in our model of care, needs to be. Speech and language was written as 0.6 whole-time equivalent per bed, but if we look at guidelines, and that was of its time, but since 2014 there have been, say, the UK staffing critical care guidelines, the GPICs there, 2019 produced, and there's some differences, big ones being that the psychologist should be included, and that speech and language therapy needs a minimum of 0.1 whole-time equivalent per bed day. Local case mix and complexity need to be taken into consideration as well. And I'll just finish up with considerations for the future, and that is to please include the HSCPs and AHP staffing for all new ICU beds and correct historical deficits when it's possible. We need scoping and updating of our recommended staffing ratios and service provided. We need to include psychologists and really occupational therapists. There's a dearth amount, although there is a recommendation in the model of care. There's very few hospitals have a dedicated occupational therapist. And again, advanced practice and extended scope of practice need to be considered, and structured formal training and CPG for HSCPs or AHPs preparing to cover ICU. And just that you know, there's a new development, there's a HSCP critical care lead being advertised at the moment, and this will make a difference. And I just have my acknowledgements there. I'd like to also acknowledge my department and my boss for releasing me this morning to come here. So thank you for listening. Thanks everyone. Thank you.
Thank you, Carmel, for that very heartfelt presentation on the importance of the HSCPs and the delivery of critical care in our country. I'd now like to introduce Dr. Dermot Doherty. Dermot is a paediatric intensivist in Temple Street in Crumlin and associate clinical professor in UCD School of Medicine. In 2014, Dermot joined the National Transport Medicine Programme as paediatric lead and oversaw the development of the new Pediatric Retrieval Service, which became known as IPATS. He was then appointed as the national lead of NTMP in 2015 and led out on the integration constituent services of the NTMP into the National Ambulance Service as a new service.
Thanks very much, Una, Mike and Derek, for the invite and for keeping us plugged into all the different changes that are coming up in critical care over the next few years. I called it a PDSA review because it is kind of to look at what we did and how we've done in the course of the pandemic. It's true to say that we weren't fully built when we went into the pandemic, and there's a lot of learning from that as we go into the future. All of our services are getting busier. It's not surprising that the MICAS service, the adult services, got busier during the pandemic, but so did the other two services. And why do we need a retrieval service? It's not untrue to say that this can be done by individual hospitals referring patients inward, but it's probably reasonable to say that it can be done better by an organised service, purely because of the fact that this is the main thing. We have clever people in the room that are focused on this in terms of the processes, the concepts, the philosophy, the equipment, the training, and borrowing from other industries such as the aviation and the military, where you have processes that have are practiced and you have redundancies of concepts and equipment. And we have that within the NASCARs. And we became part of the ambulance service a few years ago because we were trying to keep up with the changes in Irish healthcare policies. And the NTMP was a clinical program that didn't really have the capability of responding to the individual needs of these services. And so we became part of the ambulance service in 2019. And all of the layers of different health policies have brought new challenges, but mainly new opportunities, because each of them we can see within these policies ways we can generate resources for ourselves. And the COVID has led to an increase in our resources coming our way, which we hope to be able to use and learning from how we've done in the last few years. I think the game changer, though, is going to be the increase in adult critical care up to 460. I think that's going to bring perhaps unanticipated consequences or unintended consequences. And I think because of the density of the adult ICUs increases to the hubs, there'll be an increased gravitational pull of those into those units. And I think that'll be where we will fit in, and hopefully we'll be able to model that. Similarly, the National Children's Hospitals already, there's only one place in to go. Children cannot be accommodated or shouldn't really be accommodated in adult units outside of Dublin. So children presenting in the periphery have to come into the Children's Hospital. And maybe that might be something that lends into the way adult medicine evolves as well, is that critical care might move centrally. We've had the components of a retrieval service for some time, and we thought we had most of this, I guess, built, where things that I've put in red there is where we have, we suffered under the stress of the system, that we've lost people as we've gone along. It's been exceptionally busy over the last 2 years. And we have to, in terms of Biden's concept, build back better and understand how that is. The way the service is structured is we have our We have our hubs, our bases in Dublin, in Cherry Orchard Hospital, where we have the 3 teams are based in our partner hospitals, with the Secretariat based in Cherry Orchard, and we have the 2 adult hubs based in Galway and Cork. We resource in a partnership with the hospitals and the voluntary hospitals, where we look for our clinical staff, and we have arrangements of finance, human resources, clinical engineering, and so on. Now that has been built over years, and some of those arrangements we have to untangle as we move on, particularly when we are within the ambulance service now. And we like to think of, whether it's true or not, is the ambulance service is perhaps can be considered its own hospital group, and we're the critical care service of that group. The principles that we have is that we want to have people that do this all the time. They focus all the time on this, but they come to us with competencies in their base specialty, whether that's neonatal, pediatric, or adult nursing, or similar specialties in medicine. And we want to have our appointments where they retain their competencies and currency in their base specialty, so that they can, when they come to work with us, they're fully equipped to be able to do the job. We want to have a cohort of trained ICU nurses who are identified as transport nurses, and they can be either within the units or supernumerary, but ideally supernumerary to the units, so that we cannot, that we're not looking for a nurse to be released, which has an impact on the base unit. Now that hasn't been possible through COVID, and we've suffered that in adults and pediatrics along the way, and we're moving towards a position where we're having nurses within the National Ambulance Service with a nursing system, hopefully with a nursing director coming this year. But we probably will move towards having a hybrid system where we have nurses that are coming from the hospitals, seconded from the hospitals, and NAS nurses. We also want to develop the advanced practitioner nursing role, and I'll go into that in a while. We have EMT and paramedicine, and we have a EMT as sort of the core grade of the retrieval services. And they have a different role from frontline ambulances, and they really are an integral part of the team, and we want to develop that. We've also developed critical care paramedic, which is essentially an advanced paramedic with training, and I'll talk a bit about that later as well. But within the ambulance service, there is synergies outside of NASCARs, which can be benefit to the ambulance service, particularly in the pre-hospital fields, that highly trained paramedical staff can add value to things like pre-hospital critical care and the EAS, or the Emergency Aeromedical Service. Within medicine, we need to be able to train junior doctors to be able to do the job, but we also have to train doctors that are going to be consultants in this role. So we have 2 arms to that, of vocational and basic training. Consultants have to be able to backstop this. Some of our services are very consultant dependent, overly so, and I'll talk a bit about that, but we need to have consultants, and the consultants that are on duty for us are on duty for us, and can't really be cross-covering other parts of their services. And again, hybrid appointments is the way we do it. I'm going to illustrate this with the neonatal team, and I know that there may not be many neonatal people on this conference, but the neonatal team is probably the most advanced team that we have, insofar as it's the most mature team that we have, and that they have had this nearly dialed in. It has a little bit of work to do on it yet, but they have a resilient system, and they are our busiest system by a margin. I'm going to introduce you the concept of the red team and the blue team. So on the, I don't have a pointer, but if you can look at the slide there, you have a team that's crewed by 2 EMTs, a nurse and a junior doctor. And that's the basic team, and that will do approximately 80% of the acute retrievals in neonates. There is a consultant and a fellow available to that team. And the consultant really comes into it where the complexity of the infant's condition requires that a consultant is there. And that's probably about a quarter of the times. The blue team is a nurse-led team where there's 2 EMTs in that, and that would be a less acute or repatriation or tear down of intensive care requirement. But if we have 2 calls at the same time, we can either put the consultant on that, or the fellow on that, or the junior doctor on that, and that becomes an acute team. So it gives fluidity in the service. And that's the concept we want to be able to move, that we match the patient's need by the resource, so that we're not hitting a thumbtack with a sledgehammer all the time in terms of what we send out. The neonatal team, I said, is the busiest team as 677 patient movements this year, and it's gone up during COVID, even though COVID has no effect on it. But I can think if you look at the diagram on the right, you can see that the rate of increase happened in October, November, and December. And if you count back, well, that's lockdown time, so I can't think what the Irish population were doing when the pubs were closed in January, February, and March. We have. You could see the complexity of their care, and that they try to do as much repatriation as possible. And often that happens when they are not tasked on an acute transport. And hopefully this year that we're going to build into that they have the repatriation, and so they're able to de-escalate or decant infants from the central maternity hospitals in Dublin and Cork, and be able to go back to neonatal units near the home to complete their care. And so that's what we envisage for the year. That's going to be a nurse-led team, 2 EMTs, and supervised by a consultant. In the picture there is my colleague Jan Franta, who is the neonatal lead. Anne Bowden is in this photograph, but Jan and Anne are the brains behind the enterprise, and have led this for years. And I'm very grateful for them for all their diligence over the last couple of years and ingenuity. Moving on to pediatrics. Pediatrics is something that we would like to, we need to put more work into. We started the Pediatric Retrieval program in 2014, and we did it as a pilot, and the pilot progress has evolved into how we do business now. And we were very cognizant that we were starting an enterprise that had to be as safe as possible. And so it was very consultant delivered. In fact, it is 80% consultant delivered, and that eventually had impact in that we were drawing from the same well of consultants who were providing intensive care in Temple Street and Crumlin, but then had to go out the next day on retrievals that could last up to 12 hours. And up and down to Letterkenny is not an easy day. And so that had a knock-on effect in terms of an actual effect on burnout. So our plan is that we have to really develop what we call the middle tier, is that an advanced nurse practitioner and fellowship level of retrieval team. The nurse, the PICU nurse, will always be the bedrock of the team, but the second member of the team should be at a higher level. We haven't been able to rely on our registrars because they haven't enough experience in paediatric intensive care to be able to be, at the beginning of the training, to be able to be sent out independently. Many of them reach that by the end of the 6 months with us, or the year with us. But they don't start out that way. So we have to move towards a senior trainee. So that's somewhere towards the end of their training or in a fellowship year. And we'll work with our colleagues across CHI to be able to develop that, both the fellowship and the advanced nurse practitioner. Education and outreach has been one of the linchpins of the service, and that in my time as being an intensivist, I can see that the effect that education has improved the quality of the retrievals by non-IPATS teams bringing patients in. That's definitely changed, and largely got to do with not me, but my colleagues, Lorraine Heary and Kathy Gibbons, and everybody that works in retrieval, and Heike Brule. The type of patient removal, it's straightforward. It's brain, heart, lung, or in the reverse order. Lung, brain, heart, and then all manner of conditions that you get in pediatrics. And it's a spectrum of everything from infants to children with beards and moustaches. Patients come in from everywhere. There's a lot of movements within Dublin, though, but in and out of Crumlin, but between ourselves, sometimes in and out of Beaumont for specialist angiography, and also Tala Hospital. They'll be supporting the services in their IPATs. Patients come to both units a little bit more towards Temple Street, reflecting that it's more a general unit than Crumlin has more specialist services than Temple Street does. So as I said, this is what I said. These are the to-dos this year. Is that we have to increase our consultant pool. We have the financial resource to it. It's hiring is the challenge. Finding the right people to do this job and integrate it into how we're going to provide intensive care in the near Children's Hospital, in one of the biggest units maybe the biggest unit in the island. And MICAS. So MICAS has had a hell of a year, and if I think back to this time last year, it was an onslaught. I don't want to anthropomorphize it, but it felt like a war. On the left-hand side of the screen there, you can see all the sort of the highlights that Anna Marie has kindly put together for us. But it felt all hands on deck. As many people we could get to get into ambulances, pulling from everywhere. To try and provide as much services as we could. We were lucky. I don't think it was anything got to do with design. We just got lucky. You heard Mike earlier on today talking about the Surge group. We call it, our slang word for it is Big and Hill, because it felt like the Battle of Britain, that sort of 1940s thing where everyone's moving pieces around but we'd see with the board or the island, we'd see where hospitals are under stress. We'd have some sort of contingency. Well, how do we get patients out of Wexford? How do we get patients out of Cavan? At different times, different hospitals gone into stress, and we would send ambulances down, and Derek and his team would call ahead and say, we have ambulances on the way, we're looking for beds. And we develop other things such as the concierge, and I'll talk a little about that in a sec. Finding solutions for how patients could access care. But we got lucky that not all places got sick at the same time. And all I can say is thank God for vaccines, because if we had this Omicron, which seems to be so readily immune evasive and transmissible, I don't know if we could have done this the way. So patients, where do patients come from? Well, they come from everywhere. They come from Model 3, Model 4s, and they go back from Model 4s to Model 3s. But I think if you look at the lower graph, you can see that patients go to the hubs. And I think this reinforces the hub and spoke model. And I think that is something that we're going to see more of. This is looking at MICAS activity over the month-on-month, year-on-year. On the top graph, and you can see January, the green bar, it's huge, and that was a result. And I say that was all hands on deck. We really weren't built to be able to do that, and it was person dependent. And we need to get into the position where we have a system that's able to accommodate this. In terms of hospital modelling, you can see where patients went to Model 3 to Model 4 back to Model 3s, but also there's inter-Model 4 hospital transfers. So that's probably organ-specific transfers because every hospital seems to have its organ. Looking at the table there, you can see that bed capacity was one another which emerged this time, which we really hadn't seen before, or maybe we hadn't looked too hard before, but certainly it was a thing that we saw this year, is that hospitals that were beyond their surge capacity, and you could, where units had set up in their HDU, they'd set up in their PACUs, and the case of many hospitals around the country where they were in their operating rooms, and then they had nowhere to go. In terms of what we're going to do with MICAS, we have the hubs, and the hubs in Cork and Galway do sort of the traditional MICAS role, that it's a differentiated patient ICU to ICU transfer. And we'll probably continue that in Dublin, but what we want to get into the space of is be able to do time-critical, complex, undifferentiated patients within the hospital system, wherever they present. And we're defining critical care is, as you would expect, it's two-organ failure or respiratory failure or dependence on complex medical device. And having that blue team, red team idea, that we will have the blue team being a planned transfer and the red team being able to do a unplanned or time sensitive. Now, what is the unmet need in adults? And we think it's somewhere around 1,000. Anne Marie and Rory did an audit several years ago, and they came up with somewhere around 850. We're doing 460, so 465 this year. We thought we'd get north of 500. But I think that in this surge, what happened is that there was nowhere to go, that the system was at capacity all the time, and at that nearly 300. And so the fluidity within the system, that everyone got sick together, I guess, is that, and there was less inter-facility motion. But aside from that, we've looked to see, it's very difficult to capture all the adult critical care retrievals, because the emergency department, or the wrong emergency department, needing to get to the right hospital is a thing that we need to be able to capture. We think there is another 300 based on an audit we did just before Covet started, and that's the subarachnoid hemorrhage presenting in, let's say, Connolly, for example, that needs to get into Beaumont, or in the Mesa Model 2 hospital, let's say it's a pulmonary embolism in somewhere like Kappa that needs to get in for somewhere that's going to get a thrombectomy. Moving on to Aeromedical. Aeromedical is the neonatal team is set up in terms of their equipment and their relationship with the Air Corps. We have a very good relationship with the Air Corps. We just don't have enough of it. We don't have really readily access to helicopters. You might argue why we need them. Well, I'll explain later. But I think Rory's slide made it clear, is that 4 hours in an ambulance is too long. We need to be able to support the hospitals on the West Coast in particular, that you're not spending 4 hours on the way down or waiting 2 and 3 hours for us to get to you. You need to get in with that 4 hour window in which impacts outcome, and Aeromedical is key to that. And so a lot of neither the pediatric or the adult team are able to readily get in the helicopter, and we are investing this year in equipment. This is you can see the middle photograph there. That's what the Air Corps have, and that's kind of 1970s looking technology, or 1980s. But it is very expensive. It is extremely difficult to integrate, and each helicopter or each plane has its own particular nuance, and so we can't be trying to configure every different compatibility. We need to pick one, and if it's our ask to government is come up with an aeromedical strategy. This year we put a lot of work in with the rest of the ambulance service, that we have a whole of service approach that includes primary, secondary, and tertiary aeromedical transfer. But it's something we need to really have, that we have some access, predictable access, for tertiary interfacility retrieval. At the moment, you could see there's about 30 neonatal done, but if we audit how many patients should have been moved by air, it's about 150 to 200 adults, pediatrics, and that's not including what might arise coming out of the trauma strategy. In terms of communications, we have the 1-800-ACCEPT number. We have the National Operations Service. So we have the ACCEPT desk, which is accessing critical care emergency patient transfer. There's a need. Many of you have used this. Press 1 for neonates, 2 for MICAS, 3, whatever it is. But we need to figure this out, because we have other things involved. The simplest algorithm we have is the pediatric one, because it has bed finding attached, but it's only one service. We need to be able to accommodate all the various specialties and bed availabilities in the adult system in a way that we can have a referral, decision, acceptance pathway mapped out easier. And we're going to look into that this year, where we accommodate the information that we get from the bed bureau into a pathway for patients that makes it streamlined, because it's still a bit of a ring around if you can't find a bed. Critical care paramedics saved us this year. Because there was of the nursing shortages, hospitals will always look after themselves, that they have to look after their own risk. And we lost a lot of our MICAS nurses from our hospitals. We had planned on critical care paramedical of 8, but they were press ganged into action very soon. We applied for 4, we got 7. They're advanced paramedics that had done on their interview, and they're very capable, competent. They were trained. Thank you to everybody in the community in Beaumont, Vincent's, Mater, Cork, Limerick, Temple Street. And they're still a work in progress. And they were able to work within their scope of practice, because we had an arrangement with the ambulance service that they were always going to be supervised by a senior doctor. And so it's either a consultant or a PG, a SAT 5, SAT 4 or 5 that would go with them. But they really kept us going, and it allowed us to flex up. The issue is, though, that they are still advanced paramedics. They operate off my license or David Menzies' medical license or Cahill O'Donnell medical license. And to get to the next stage, the legislation needs to be amended to create a new grade of specialist paramedic. And we're really looking forward to that, because we can't move it on until that happens. So if anyone is in cyberspace from the Department of Health, please amend the legislation as soon as possible, because we feel this is an integral part, along with advanced nurse practitioner, to be able to move forward MICAS. The teaching and training took a torpedo during this as well. It was very difficult to do this, but we got a lot of it done down to the perseverance of Anna Marie and David in MICAS and my colleagues in neonatal and pediatrics. Less than that's before, but it involves with partnership with the College of Anaesthetists, on-site training. You can see there's a simulation in the Mater, getting ready for the trauma networks but we have to get back into that space where we be able to keep on this, because it lifts all boats, this on-site training. So we need to restock and rebuild our capacity to be able to teach, and hopefully with the reduction in restrictions we'll be able to do that on site as well. So I've said this is where we're going this year, is that we get the blue team and the neonatal going in the next quarter. We have 2 appointments, and that's the neonatal team, I hope, built. We might get another fellow into that, but we'll have 6 doctors on that service. It is extremely busy. They're heavily committed to this. It's an onerous job, and I'm very grateful to my colleagues and the service they provide in the neonates. Again, pediatrics is really dependent on locum cover at the moment. We need to be able to move past that into, as I said, something that is sustainable within the critical care and anesthesiology sections of the new children's hospital. Develop that middle grade of nurse practitioner and fellow to be able to support retrieval. And again, be able to do blue team for pediatrics, which is complex children. So a lot of hospitals struggle with this, where children are moved on high flow oxygen, for example. You need a special ambulance with enough gas to be able to do that, and the knowledge that a specialist pediatric nurse be able to bring to those complex patients. We must develop rotoring capability as well. For MICAS, again, it's to build, restock and rebuild it. Appointments into our key partner hospitals we're still negotiating with that. We've had two unsuccessful recruitment campaigns. I'm not disappointed with that. I think it's very dependent on getting the right type of person, because this is not for everybody. You need have a certain leaning to be able to do this type of work. And I'm confident, by having talked to our trainees, that there are very good trainees that have declared an interest. And anybody watching this, come and speak to us if you think this is going to be a career. And then again, back to the governance of the organisation, we've been shelled and lost people left, right and centre, and we have to rebuild that, because our governance structures have kind of melted away, because we have been delivering clinical services, and we need to be able to come back and be able to look at the data, analyse it and rebuild it and restock. And finally, critical care paramedic, as I said, we are very invested in that. The ambulance service is that, but it just needs that line, and hopefully this year in adult and pediatrics we get advanced paramedics. Thank you to all my colleagues from all 3 services, and I think that it's been a very difficult year. We've left a lot of bruises with us. I think we have risen to it. I'm not sure we could have done it again if this had happened, if this wave had gone a different way. I'm very grateful to scientists for inventing vaccines. But again, thanks for everybody in the audience, and good luck.
Thank you, Dermot. We're going to take a break now for lunch. We'll be back to you at 2 o'clock with a very moving story, a patient experience. I want to thank all of our speakers this morning. I want to particularly thank our Minister for Health, Mr. Stephen Donnelly, for attending. I want to thank Mr. Paul Reid, the CEO of the HSE, Dr. Rory Dwyer, Dr. Martina Healy and Dr. Mike O'Connor, Dr. Brian Marsh, Eileen Whelan, Carmel O'Hanlon and Dr. Doherty. And we'll see you all again at 2. Thank you.